Well, welcome. Thank you all for taking some time out of your day to join us today. My name's Keith Foley. I'm a physical therapist. I work for Joint Ventures Physical Therapy, and we were just discussing we're on the Southern Artery in Quincy Point over by Comedian MD and Jersey Mike's. So I was here, I think in the spring, for a fall prevention workshop, a very similar format. A show of hands, was anybody here for that? All right. So I really enjoyed that, and it was great. Got to work with a lot of great people afterwards. But the reason why Marley and I were talking about doing this workshop was a couple of the questions at the end had to do with arthritis. And obviously it impacts all of you, that's why you're here. I work with it a lot in different spectrums, and I think there's a lot of misconceptions and what we'd call myths regarding osteoarthritis and how to treat it and how it can impact your life. Our culture and society, based on history and how we talk and how we socialize, these things become very prevalent in our culture, and these narratives can also, I feel, restrict people's activity, their quality of life, and really have an impact on their pain. So I love doing community events like this where we can talk about it, engage, and you guys can hopefully learn a little bit. I call this topic, the wear and tear truth, demystifying osteoarthritis and exercise. Has anybody heard arthritis is wear and tear on your joints? Okay. I've been doing this for 20 years. That's how I was taught. But in the 20 years that I've been a physical therapist, we've learned a lot, and it is not that simple. We are not machines. We are living, breathing creatures. We're more like gardens. There's a lot of things that go into our bodies and a lot of things that cause these things. But it's not as simple as wear and tear, and we'll kind of talk about as we go. But hopefully if you learn one thing today, it's that is not true, okay? I always like to, when I do topics like this, like we did with falls, talk about why is this an issue. All right, so the pain point of osteoarthritis is it affects 17 to 21% of the American population, and that's all ages, from newborns to later in their life. So even in that, it's still about 20% of our population. 600 million people worldwide that live with osteoarthritis, and that's 32.5 million Americans. One thing that's, I think, timely for where we are right now is that number represents an increase of 132% since 1990. I think of it as, in 1990, especially into the 2000s, our labor and our workforce has actually gotten more sedentary, right? We're not like we were in the Industrial Revolution. We're not working in farms. We're not working in factories. So if we're at large a more sedentary society, why is this continuing to climb up, right? If it was simply wear and tear, you wouldn't think that would be the case. Projections indicate nearly 1 billion people can be living with osteoarthritis by 2050. You probably realize the knee is the most commonly affected joint by osteoarthritis, followed closely by the hip, spine, and hand. I mean, I'm sure you guys know people that have had knee replacements or multiple knee replacements, meniscectomies, or people have bad knees. It is the most commonly affected, but I also think it's the most commonly screened, and we'll get into that. Medical costs for individuals living in the US with osteoarthritis during that period of time are almost $70 billion. We'll touch on, there's an industry on pain that preys on you, preys on me. If I mention it around my phone, if I say something about back pain, my Instagram algorithm will just pump me with different devices and braces that will help me. Over the age of 60, 35% of women and 20% of men are burdened by osteoarthritis. One thing we do know, and we'll talk about it, is women, and even by a show of the audience here, are more impacted by arthritis than men. I'll do a very brief anatomy lesson. Osteoarthritis, what does it mean? Osteo is the bone, arthritis is joint inflammation. This is distinctly different than like rheumatoid or psoriatic arthritis. There's other inflammatory conditions that cause that and go into it, and they also can be treated by exercise, but that's not the point of this one. This is the more commonly known osteoarthritis. It's a progressive degenerative joint disease where cartilage is slowly broken down over time and increases the shear and compressive forces on the bones that connect with the joints. That's some of the noises that you hear when you have osteoarthritis. Is the crepitus, is that shear compressive forces. Over time, that can lead to joint inflammation and loss of cartilage due to multiple factors. We now know, and we'll touch on this as we go, systemic inflammatory factors are bigger risk factors for osteoarthritis than the wear and tear. So that's what the multiple factors are. The other thing that I like to talk about when it comes to this is the inflammation is usually the pain that then drives you to have imaging, which finds this. And a lot of times it's a slow progression of things. There is post-traumatic arthritis that we'll touch on too, but it is a slow creep that builds you to this point. And there's been a push in our industry as we study these things that cartilage, like meniscus, the labrum of your hip, the labrum of your shoulder, even things that aren't arthritis like your rotator cuff, okay? There's chronic tears in the rotator cuff. There's chronic fraying and degeneration of your spine. You've probably heard that too. We now think that, like, studying this from an evolutionary perspective, they're kind of what we would call sacrificial tissues, meaning we're actually designed for these things to break down, and there's redundancies in them. The rotator cuff itself, you can have a lot of tears, you can have full thickness tears and be pain-free. There's a reason for that. There's what they call a rotator cable in the center of it that's the thing that holds it together. But because we're designed to use our arms overhead, push-pull things, there's redundancy that you're going to have tears, but that's okay. But what happens with a lot of these things, and we'll get into imaging, is you have a sudden onset of pain, concerning. It doesn't really go away in 24, 48 hours. You start to investigate it with imaging, and we find these things that may or may not be false positives. All right, so same thing with the meniscus of the knee. We're designed to be bipedal on our feet, use our knees and use our legs. The meniscus are really thick fibrous cartilage that is actually designed to wear down over time. That's not a bad thing, that's actually a normal thing. All right? Kind of reframing how you think about some of this stuff. All right, some other terms. Joint just means a connection between two bones. All right, it includes your bones, your cartilage surfaces. Every joint has a little bit of fluid in it. And then a capsule, ligamentous capsule that keeps everything encapsulated. The cartilage is the connective tissue that develops in utero on the ends of the bones that provides shock absorption and reduces friction and provides structure within a joint. There's three types of cartilage. The meniscus is what we would call fibrocartilage, all right, that thicker cartilage. Elastic cartilage is very rare. It's, like I said, the ears and the vocal cords, tissues that are designed to be flexible and dynamic. Hyaline cartilage is also throughout your body, and that is like a thin, waxy coating of the bone. That cartilage is actually more, if that is damaged, that's more serious. The fibrous cartilage, like I was saying, is more of the sacrificial, yeah, somebody's phone, not mine. The fibrous cartilage is the one that's more that sacrificial tissue that I'm talking about. The hyaline cartilage, if that's damaged, that's typically a more serious problem and more painful. Still can be managed through exercise, but that's where, like, if I, as a physical therapist, am going through my treatment program and things aren't adding up, I'll refer out to be like, maybe there is a deficit in your hyaline cartilage, which can be trickier and can be managed also with some other procedures. But the fibrocartilage is what you would, again, talking about the knee and the hip, the labrum of the hip or the meniscus of the knee. Why does cartilage not regenerate? That is there's a lot of people trying to figure that out right now. Where I'm landing right now, this is 2025, is more that sacrificial tissue kind of thought process that I don't know if it was ever designed to regenerate. There's a lot of people trying to do things with stem cells, and trust me, if somebody could figure out how to regenerate cartilage, they will be a zillionaire. I don't know how much money they will make, but they have not found a way to do that yet. For me, I'm not going to bore you with all this stuff. The biggest thing we can do with exercise is by moving and changing the way we move and moving frequently, we can redistribute these cells that trap water in your cartilage, and you can get them more hydrated, right? So we can redistribute the hydration of your cartilage that is there, and that can help with the movement, right? And we'll talk about different types of movement, but that's at a cellular level, initially, that's what we're trying to do with a lot of the exercise in physical therapy and different things, is redistribute that, and that will help it stay healthy and preserve as much as we can, okay? The water is all throughout your body, so it's even in your cartilage. Another reason that I didn't touch on there, a lot of, like, depending on what zone you're in the meniscus and different tissues, some of it is more vascular than others, and also is why it's more prone to that. And the vascularity, we can also increase the blood flow to certain areas. All right, so risk factors for developing osteoarthritis. Greater than 40 years old. I'm 45, so like I'm at a risk factor. But age is a huge one. There's always a genetic component, right? How we're designed. I'm sure if you talk to family members, you guys have similar ailments. You know, I've had a hip issue. My mother had a hip issue. That is not a sentence, but it's a risk factor, right? History of previous ligamentous or disruption of the joint or a traumatic injury. All right, so for me, this is why when I get a young athlete who has, like, let's say an ACL injury, a complete rehab is getting them obviously fully functioning back to what they do, but also establishing an exercise habit that they understand just based on that injury, they're at greater risk for developing this. And not that you have to do PT exercises, but you do have to strengthen and take care of your legs throughout your lifespan, or this could be a factor, right? So that's part of my end game with any young athlete or younger person that has a ligament injury or some sort of traumatic injury. And then back to what we were talking about, systemic inflammatory conditions. So diabetes, cardiac disease, these types of things actually put you at more risk for arthritis than activity or like wear and tear. That goes along with obesity and being overweight. I think the best way to think about that also is the further down your limb, all right? So obesity and weight is gonna affect your foot and toes and ankles more than your hip. Your knee is the next one up, so I think that's also why the knee is more commonly affected than the hip, right? The further down the chain, the more weight makes a difference. That's why, like with back pain, I don't think it's the first line of defense, but with knee and foot issues, I do think it's a conversation that you need to have as far as trying to mediate and manage your weight loss to help take some load off of your body, all right? One thing we talk about, we'll talk as we go, we objectively measure quad strength in individuals that have knee pain. And one thing we know is if you're gonna go down a step, your quad has to have the ability to bear the weight of your body, right? So you have two choices. You can lose a little bit of weight, or you can really get your quads strong. And those two things usually meet in the middle somewhere as you go. And then back to, I think these three things kind of all go together, but sedentary activity is actually more of a risk factor than activity itself, all right? There's kind of a disuse thing. Your body has a lot of sensory inputs, and if this happens a lot with bone injuries, like fractures. We used to get a lot more non-union fractures because what would happen is you would break a bone, they put you in a hard cast, and you wouldn't load the injured area for a very long time. What happens is your body gets the message, I don't need that bone. I don't need that part of my body. I've gotten around not using it, so I'm not giving it any input, so why do I need to waste the energy to have it heal? And then things wouldn't heal. So sedentary activity, if you're not loading your joints and doing these things consistently, your body's gonna get the message of, I don't really need this, right? I can get along without it. So that's a very simple way of a lot of groovy things that are going on in your body. All right, my soapbox, misconceptions about OA risk. Probably heard throughout your lifespan, running is bad for your knees, squatting is bad for your knees, lifting heavy things is bad for your back, and strength training is dangerous. None of that, when you research it, none of that is true at all. Strength training is actually one of the more inherently safe things you can do. All of these things just come down to what is your entry point, and are you doing too much too quickly? It's not the activity itself. So a lot of people have pain with running because we live in New England, it's starting to get cold and dark out. They don't run all winter. March, April comes around, it's a beautiful spring day, let me go run 3 miles. Bad idea. Your knee's gonna get really flared up, or your foot, you're gonna get some sort of injury, and then it becomes this cascade. Lifting heavy things, people don't consistently strength train, don't prepare their body for it. Again, summer comes, let me get that AC unit out of the basement, pick it up, there goes my back. It wasn't that activity, it was you were not prepared for that activity. And we gotta kind of change our mindset around that as well. Any questions so far? Any thoughts? All right. This is one of my favorite infographics from a great study from the British Journal of Sports Medicine. And this is about myths about recreational running causes knee osteoarthritis. I can send some of this to you, but really the takeaway is marathon runners that are studied compared to their age-related controls have less incidence of knee arthritis, right? And it just was like always assumed that that was like, don't put too many miles. I've like literally heard surgeons say, don't put too many miles on your knees. You know, you only have so many miles. It's not true. Those marathon runners are consistent. They're remarkably good with their programming. Their cartilage is healthier as they age than people that don't use it. But if you have any other questions about this, you know, we can really get into the weeds. But like, I think this is a study that I always highlight to a lot of people that get that information before they come into my door. Symptoms of osteoarthritis. Pain is the number one symptom, right? That's what, you know, noises happen, but I always say noises don't bring you usually to the doctor. Pain is what brings you to the doctor. Pain is what brings you to my office. Pain, which we'll go into in future slides, does not always correlate to the extent of degenerative changes on your imaging. You have people that have, you would be surprised with their knee function. Like I've had the privilege of treating people that for like back pain, and then you'll see their knee, and you'd be like, does your knee, it's like turned in, let's say. It's like, does your knee hurt? No, it's been fine. It's been like this my whole life. Your body can adapt, right? So typically what happens is you get a pain or you get some joint inflammation, you get an inflammatory cycle, then like there's a cascade of things over time, and when you're in that pain and inflammatory cycle, that's when you seek medical attention, and then you get the imaging. So then you say, oh, I must be in pain and inflamed because of that imaging. But if you took that image a month before the pain and inflammation started, it probably looked pretty similar. Maybe there was a little bit more degeneration, but it wasn't like all of a sudden it happened like that. Stiffness, common symptom of OA. Who has joint stiffness? I do, yeah. Again, stiffness is sometimes a perception, it's a sensation. Stiffness and loss of motion don't always that's always not one-to-one too. But our mantra with stiffness is motion is lotion. It's sometimes hard mentally to do it each day, but motion is lotion. The other interesting thing that like you don't know until you get evaluated by somebody like me is muscle inhibition. All right, so sometimes weakness or muscle inhibition just comes on because of pain and inflammation. Okay, the pain, your body has no like pain. For survival and like evolutionary-wise survival, it's going to downregulate the joint to protect it, right? If it's having pain, it's not going to tell you to use it more. It's going to inhibit your muscle strength and power because it wants to protect the joint. And part of my job, which is tricky and fun, is to trick the nervous system to allow that to happen. Joint swelling can also affect it because you have sensors in your ligaments, tendons, and muscles that it can tell because there's an increased volume that it's not in the same place that it usually is. So those stretch sensors then again inhibit muscle function. So some of the weakness that we see when we work with people and individuals with this is not because you're weak, it's because your body is in pain or swollen and it's trying to protect itself. And if you can manage that correctly, you can get out of that vicious cycle quickly. Happens to people after surgery too, right? You have a knee replacement, your body knows it's been invaded, it's been quite a trauma, it's going to swell up and it's going to inhibit, and you're going to see people like their thigh will go from this size to this in an instant because your body is trying to protect and preserve that joint because it knows it's been invaded. So it's trying to do that, and our job is to, like, again, tell it it's okay and gradually decrease that inhibition. It's very, the body's a very, very amazing thing. All right. Another big one I wanted to make a point here with this is you are not your image. All right. So there's been a lot of studies. This particular research review stopped in 2019. There's been even more, especially in the back. But I like to point this out. In 45 to 6-year-olds, greater than 50% had what's called a slap tear, which is a tear of the cartilage in their shoulder. Okay. I, for one, have one in my right shoulder from falling and playing some sports. I've never had surgery with it. You can definitely manage and get around it without surgery. This one's probably one of the biggest ones, lumbar disc degeneration. 37% of 20-year-olds have some degree of degeneration in their spine. Again, back to the sacrificial tissue kind of theory. It's kind of normal, right? Like, in a way. Not normal at 37 because that's still less than 50, but 96% of 80-year-olds, yeah, like you're going to have degenerative changes. So, and I think this has actually gotten out more in the medical community with radiologists and doctors. In my 20 years, I see them explaining degenerative disc disease, if it is of your neck or your back, much better than they were 10 years ago. It's kind of decreasing some, because if you're yourselves that don't have a medical background and you get an MRI or an X-ray and it says disc degeneration, that's pretty concerning. But it is really a normal finding. Just because my wife's pregnant right now, she's at advanced maternal age. Like, if you don't, yeah, exactly, it happens at 32, right? If you don't, you're like, oh my God, so it has to be explained a little bit better sometimes, these things. And then back to the knee, in 20-year-olds to 69-year-olds, there's 89% of a meniscus tear degeneration. So, like, even in a young athlete or a younger adult, we don't surgically remove the meniscal tears like we used to, because what we've learned is it actually accelerates arthritic changes. Now, there are, based on zones of the meniscus and severity of the injury, there are still indications to do it, but it's a lot rarer. In the 90s, they were snipping and cutting everybody. And just because I know the Red Sox are somebody that, an organization a lot of people know. Does anybody remember Dustin Pedroia? He was like a Red. So in my opinion, his career was derailed because every offseason they were snipping and taking out a little bit of his meniscus, and he already has a knee replacement at his young age because they were thinking of the timeline and everything else, and they never tried to really get at the problem and rehab it, and they kept on snipping it, and that's what led to the end of his career. He was a great player. So now, they also did some studies, which I think I get into, about sham surgeries and just comparing. The reason why the surgery, the meniscectomy, would work is because you would basically have the surgery and you'd be shut down for 6 to 8 weeks, and then you'd gradually rehab it. So what they did was say, okay, what if we just do a sham surgery where we don't do anything to the meniscus, we just put a scope in there, and we just do the same exact thing. And the outcomes were better, if not the same, right? So then that's why Medicare doesn't even really pay for their surgery anymore, and it is rarer to see. All right. So using the data from the Framingham Osteoarthritis Study, 710 individuals without knee OA went through this study on imaging. And 87% of those without pain in their knees had abnormalities in their knee. So again, a lot of times, if you know a friend or family member that is getting imaging and doctors are making the decision solely on the imaging, that's out of date, right? The imaging is the last step to confirm other things. It's not saying that imaging is pointless, because it has a place. But if you're using imaging to solely make your decision, it's really about quality of life. Have you tried conservative therapies? Have you tried conservative therapies correctly, because I'll talk about physical therapy in general, that not all PT is the same. Have you tried less conservative things like injections and things like that? Have you exhausted all those things? Okay, and you have this? Yeah, you may be a candidate for a knee replacement. But if you're just going to a doctor and you're making the decision off of an x-ray, you're skipping a lot of steps, okay? So I broke it down into 4 different things. Medical, which is usually the first line of treatment, and the entry point, like I said, you usually have pain and inflammation, you seek medical attention. We've touched on imaging and its relevance before. One little thing is, we as physical therapists in Massachusetts do have direct access. I'm not saying, I don't think people should go to orthopedic doctors in any which way, but sometimes that can create a bottleneck. And what I usually tell people to do is we do those 2 things in parallel. You can come see me and come see a doctor at the same time. We don't need to be kept by the doctors. And you do have direct access in Massachusetts to see a physical therapist. Now with Medicare, the way that it works, which I think is good, it also requires a doctor to sign off on a plan of care. So you can't just see me either, but it doesn't have to be, you have to wait for a wait list to get in, and then by the time all that happens, you're 2 months down the road, and then we're fixing problems that we could have gotten out in front of if you started with us. Surgical, like we talked on the meniscectomy for the knee, but even like hip labral surgeries and all that. None of these, in my opinion, unless there's some sort of trauma, right? Orthopedic surgeries are amazing for trauma. You know, that is where that should be the first line of defense. But if it is these insidious onsets of repetitive stressors that cause pain, surgery should not be the first line of defense for any of those things. Then there's physical therapy we'll dive into, and it should be exercise-based. We'll talk about modalities. I'm lucky I work for a company that allows me to practice at a pace that I get 40 minutes one-on-one with everybody. I don't pass people off to train like rehab aides or students or anything like that you're with me and I'm constantly assessing you each and every session. And the evidence nowadays points to a multifaceted approach of exercises with education, which is part of why I'm here. Like education goes a long way, because even the people that I work with, I always have the saying, you're with me maybe 1 or 2 hours a week, but you're on your own a lot longer. And I have to teach you how to operate in those hours too, because all of it really counts when you're talking about these types of pain. Device and braces, there's utilization for them, but again, there's an industry on pain, and it should not be your first line of defense, right? If you get if it's an ad on TV or on the internet, or you just decide to go to CVS and get a brace of some sort, but you're not, and you are dependent on a brace, and you're not trying to do any active approach to address the pain, you're really missing the boat, right? And you're only setting yourself up for worse things down because you're not listening to your body's signals and adjusting. You're just kind of trucking through. So there's a reason for devices and braces of sort, but less than you may think. Some of the more common medical treatments. Injections. Injections have a place, but they also have a lot of like powerful effects that you may not realize. Especially with tendons, cortisone and steroid injections can really weaken the tissue and make you actually more susceptible to injuries down the road. In cartilage, similar thing. I'm less alarmist about cartilage, because I do think there is a place, but it also should not be your first line of defense. And I've met plenty of people since I've been working in Quincy that almost go for like scheduled biannual injections. That is a great way to destroy your cartilage. Like your cartilage is just getting demineralized every 6 months or however often you go. Yeah, you feel good for a little bit, but then what those people start to notice is the effects are shorter and shorter and shorter because the arthritis is getting worse and worse and worse.
It's like a temporary Band-Aid.
Absolutely, absolutely. And there's a reason for Band-Aids, right? Band-Aids are good. And like, there's times when I have somebody has a really hot knee and they just are very reactive. And I'm like, I think an injection will be good just to get you out of this like really sensitive, irritated cycle. So there is a place for them, but again, they are just overprescribe because as a society we like quick fixes. We really do. Synvisc is anybody familiar with that? So it's a viscoelastic kind of injection. So we talked about the fluid in the joint, and as we age, the fluid is less. So there's some artificial fluid injections. I've yet to really ever see that work well. And maybe I'm a little biased because I maybe see the people that it doesn't work well with, but even the people that I've said maybe you should try it or a doctor is like offering it, I've never seen an amazing outcome. I haven't seen like terrible things from it. I mean, there's risk of infection in any of these procedures, but I just haven't seen great outcomes with it. Stem cells and platelet PRP injections, which is platelet-rich plasma, I think they like logically make sense to me because we're using tissues from our own body to help heal. My biggest issue with them is they're not covered by insurance because there's not pharmaceutical companies paying for it. But if they're covered by insurance, I would probably prescribe or like educate people to do them more because I don't think there's a lot of harm or downside, but they're very expensive procedures and there is no evidence that either of them work. Things like this kind of fall into the same category as glucosamine chondroitin and some other holistic treatments. There's a very individual response because we're all different. Sometimes the only way you know that they work is by experimenting with them, right? So supplements like glucosamine and chondroitin, again, logically make sense to me because they're naturally occurring in your body, but the only strong evidence for that working I've seen is in cats. Cats, yeah, it works great in cats. If you have a cat and is struggling with arthritis, give it some glucosamine, it'll be great. But in humans, it's a very individual response. Some people take it, they feel really good, and they stop taking it, it's like, I kind of notice the difference. Yeah, absolutely, there's nothing wrong with that. But it is not, it's been studied, and none of, like the stem cells, the platelet-rich plasma, none of that has been really deemed to be that effective that I feel like you should spend your hard-earned money if you're on the fence. If somebody, here's another thing about treatments, if you believe it, and you really believe wholeheartedly in the treatment, it's gonna help you more than somebody that doesn't believe in it, right? So if somebody's very passionate about these things and they wanna try it and they have the resources to do it, I'm not gonna get in the way of those things, as long as the provider who gives those treatments also tells them exercise is important, right? That they're not just saying, like, just do that and you'll be fine. Prolotherapy, I think also can be covered by insurance. I do work with a couple doctors that do it, and I think that's an interesting thing. Prolotherapy is they take needles and they like fenestrate and like damage the cartilage or the tendon to stimulate blood flow. So again, I think that does make somewhat sense. It's kind of painful, but I do think it makes sense that if you're stuck in a chronic phase, stimulating some sort of inflammation to see if your body can heal back to like having sensory tissues, that does make sense to me. But again, not in isolation. Like if you just do that and you don't change anything, probably not going to do it. But if you're doing all these other things and you're kind of stuck and you do that, they may nudge you along the way. Collagen and vitamin D. So those ones I really like. Yeah, I like those because they're cheap. Okay, there is some effectiveness to them, especially women in collagen. I'm a big advocate to, it's a low-hanging fruit. Again, if you're willing to spend the finances into it and it's not nearly as expensive as stem cells, I think it's really good for your bones. It's good. It's been proven really well for tendons too. If I have people that have multiple tendon injuries, I get them on collagen supplements and vitamin D. Omega-3 fatty acids, good for anti-inflammatory reasons, right? So the collagen is good for more of the cellular, and the same with the vitamin D. The omega-3 fatty acids are good for the anti-inflammatory. But again, none of that's guaranteed. There's just like a little bit of individual experimentation. There's a really great website that's a clearinghouse for supplements. It's called examine.com. They're a third party, not affiliated with any of these supplement companies. They're my go-to. I personally take creatine, protein, and omega-3s daily. And that's my resource to like kind of vet some of this stuff, because supplements could be created out of Joe's basement in Squantum over here. So you gotta kind of do your due diligence with that.
Could you repeat that website?
Examine.com.
Examine like EX.
Yes, yeah.
What do you tell them?
Turmeric, a similar thing. So curcumin is a similar thing. Some people love it and swear by it. Go for it. Like you just gotta see, like, does it help? Like,
Yeah,
but
people say that, oh, I'm out of it and I can feel.
then you know
and it's like, it could be mind over matter.
it could be.
Yeah.
But again, back to this point in my career, placebo is not a negative thing. Placebo is positive. If it helps you move, go with it, right? Yes, sir. I know you raised your hand at one point.
You answered the question.
Good to hear. All right, and thank you for bringing me back to that those points. That was good. All right, surgical treatment, joint replacements. Everybody know about those, right?
Oh, yeah. I had one a year ago, it still hurts today.
Okay, so that is a good point. Like you're replacing the joint,
Oh, yeah.
all right? And if it's, let's just use your knee as an example. You're replacing the femur and the tibia
Yeah.
and this joint surface there. But your knee also has an extra-articular joint called your patellofemoral. It has soft tissue, your tendons, your muscles, your ligaments, your IT band. There's a lot of other structures that if you don't rehab properly and get them up to speed, you can still have pain. I do think they're good. If you put me on a soapbox with this, I think they're just overdone because I think people default to the imaging and want to, again, a fix, and they think arthritis is a wear and tear disease and I have a tear in your meniscus and I can't fix your meniscus, so how is the exercise going to help me? I get the cognitive dissonance of that, and I'm always mindful of that when I interact with people, that like I'm basically telling you, you have a structural problem that is causing inflammation and pain, right? But you have that structural problem that I can't actually fix at a tissue level. But then I'm telling you on the same side that I can help you feel better and live a good quality of life and get you stronger. I get that cognitive dissonance. It's a very hard thing to grapple with when you're thinking the body as a machine and that there's a broken part. You think, I need to replace that. So again, it's still a wonderful surgery. It gives people great quality of life. There's excellent outcomes. They've come a long way. When I was younger, it'd be like, I think I got 7 years on this prosthesis. Now these knees last forever. They're very active. It's not as much of a salvage operation as it used to be. Hip joint replacements, I've gotten back to playing basketball, running marathons, like especially the hip joint is really a wonderful treatment at this point. Arthroscopy, like I said, we don't do that as much anymore, but there is a time and a place for it. Joint fusions, especially at areas like the big toe. You don't fuse a knee, you don't fuse a hip, but at some of these smaller joints, the fusions in the spine, it can be indicated too. But again, I think they're doing them in the spine a lot less because they're realizing these degenerative changes are kind of normal. To my passion, physical therapy. The hardest thing I think for a lot of people to get is that loading the arthritic joint is actually protective towards further OA development and progression, okay? It is really hard when you have that type of pain. You feel that noise, the crepitus, to like convince yourself to move and push in. I get it. Like it is hard, but it's just like, again, my job is to find the right entry point that afterwards you're not in agony. All right. So I think of it, and we practice with like a 3-stage approach. First and foremost, it's to like restore range of motion of the joint and get the joint moving, what we call joint mobilization. Then it's about restoring the local load tolerance and force production, which is a fancy way of saying strength, right? And I say load tolerance and force production because I think of load tolerance to the joint, force production is the muscle, okay? And then as we're doing all that, we're trying to improve your functional capacity and gait, right? So this is the local issues, and this is more the global organism issue of you as a human being. Mobility. When I first started as a PT 20 years ago, I would, if I got a knee replacement, I'd lay you on the table and I'd joint mobilize and move your knee for you. After 10 years of arm-leg wrestling with people, I've stopped doing that because I think it's more effective for you, the individual, to learn how to mobilize it, right? So it can be performed by a physical therapy, but it's better performed when you do it independently because, again, you're only with me for 2 hours a week, maybe. You're on your own a lot longer. The way that you change joint mobility and the length of certain tissues is high frequency, low intensity, right? So if you're doing, it's the other side of the coin from osteoporosis. To stimulate bone, we want high intensity, low frequency. But for range of motion, we want high frequency, low intensity. So one of my favorite exercises for somebody with a stiff knee is, I'm just going to put my foot here, is you just get on a step or a chair and, okay, I'm stiff there. Pressure on, pressure off. Pressure on, pressure off. And maybe within a bout of doing 30 of them, I gain 5 degrees, okay? Later on in the day, you do it again. You do it again. And if you gain a degree a day or 5 degrees a week, eventually you'll start to get deeper into those motions, right? And then back to that original slide that I was talking about, the redistribution of the water in the cartilage, that's what you're doing each and every time you do that, right? So my mindset when I'm working with you guys is what tissue am I addressing? What tissue am I going after with the exercise? I'm not going after muscle there. I'm going after your joint. And it's high frequency, low intensity. And that helps the cartilage that's there. And it helps get things moving that it pumps out some of the inflammatory factors, okay? Flexibility for the soft tissue, I like long duration, low intensity or low load stretching. So an example for that is say like if we're trying to get some of the knee fascia in the back or the muscles, is I have people sit with their leg up and propped and they put like a bag around their knee with like a light weight and they just try to sit there for as long as you can tolerate. At first you may be able to tolerate 2 to 3 minutes, but I give them the parameters that they're trying to get up to 60 minutes a day. However you get there, if it's 6 bouts of 10 minutes, if it's 12 bouts of 5 minutes, however it is, and then you gradually try to increase that. And you can do that at a lot of different joints as well. The goal is to improve the mobility so that the joint surface are more, the forces throughout the joint surface are more evenly distributed. So for instance, with a knee, you don't realize this, but there is a little like screw home effect. So when you kick out, your toe goes out a little bit. And when you come in, your toe goes in. So there's a little bit of rotation. And if you're stuck that either, say you can't bend, that's gonna load the medial side a little bit more than the lateral side of your knee. So over time, cumulatively, that's how you get arthritis in one compartment from the other. Same thing with the knee extension. That could be like because you can't get that knee extension, you're walking in a way that you're loading the lateral side or vice versa. So when you restore the motion, the joint is able to distribute that load a little bit more equally, which then doesn't irritate that spot. And that's another way you can get out of the pain and inflammation cycle. All right, resistance training. Tolerance versus capacity, right? So this is the question I always ask myself when I'm starting with somebody. Is the reason why they can't do this because their joint can't tolerate it and it's just sensitive to it? Or is it they just don't have the physical strength and capacity to do it? Right? Two different problems that can present itself with the same functional limitation. Let's say going down a stair. Is it because the knee joint is so sensitive to the force of gravity in your body weight? Or is it just like the quad can't do it? All right. Is the ankle joint or the Achilles sensitive to pushing off, or do you just not have the strength to do it? Is your shoulder, when you go overhead, is it that you don't have the muscle strength to do it properly and you're compensating, or is it that when you get up there, the pressure there hurts the shoulder, right? Or weight bearing and different things like that. So that's a big philosophy that we use with physical therapy. Then we use progressive loading to build strength and function for gait. These things take a long time, so our goal is to, we usually start, like I call it an onboarding process, that you may start with a couple visits a week with me, but then as you're going, we should taper down that you're coming maybe once a week for a little bit, and then you're coming every other week, monthly. In an ideal world, that's how I like to treat everyone, and then I start to offload the exercises to you when you get more comfortable, because it's really about consistency that's going to be the best. And then it's not like, oh, you've been coming to me for 2 or 3 times a week for 12 weeks, you're done, now you're on your own, right? That's a really hard transition. We try to like kind of grade it off like that and fade you off. The third one is probably one of my favorite things. When I prescribe an exercise, I don't give you a bunch of word salad anymore. It's about constraints versus affordances. So what I mean by that is if I have a sensitive knee my squat is gonna look like this, okay? If my knee feels good and I'm a healthy individual, the squat should look like this, right? Yeah, see, the joint, that was just air, but yeah, being on my feet. But so the difference is, if I have a painful joint, I'm gonna stress shield it. When I go like this and I don't let my knees come forward, I'm putting more of the weight in my butt and my back and not putting the weight through my legs, right? So an exercise that we would use is what's called a wall sit or a wall squat. We use a lot of walls, right? Because then I have to use my quads and I can't use my butt or my hips to compensate for it. There's other ways that I do it that like I'll play games where like I have somebody, I'll just put a foam roller behind them so that when they squat, they can't like knock it over, and I'll be like, just try to go straight down and don't move it. We also put people up on slants in different foot environments to like make them do certain things.
The yoga ball.
Yoga ball behind you can work really well. The other thing about constraints, machines are really good. So exercise machines used to get a bad rap that they're not functional, but strength is functional. So if you have a really cranky knee, a great exercise is a knee extension machine. Because you know what your knee can't do there? It can't hide. It has to work, right? Your hip, your back, your ankle can't compensate for it. So we have some really nice machines that we use because if you have knee pain, I'm gonna force your knee to work. Now we start really light and we gradually progress it, right? But machines are really good because it forces certain muscles to work. Same thing with hamstrings and other things like that, calves. Because like another simple one, right, is a calf raise, right? A calf raise should look like this. But when you have a painful Achilles or you're really weak, you end up just pitching forward a little bit and you take all the demand off of it. Or what you'll do is you'll have a little bit of a knee bend, right? And you're using your quad muscle to vault up. So I have some machines and other health clubs have machines that you can use that forces your calf to work and doesn't let you compensate. So constraints versus affordances. We like to, when we're doing things for rehab for painful joints and painful areas, we like constraints because it forces you to use them. And then what we do, what we pride ourselves on, as opposed to those manual muscle tests, we have some dynamometers at our office, and we have other like lasers, and we have things that we like to test. So it's not, hold, don't let me move you. Yeah, I think you're stronger than me, so I think you're fine. It's, you sit in a, like for your quad, we sit you in that knee extension machine. You can't move, we put you about 60 degrees, and you kick as hard as you can. And you do that on the other side, and we do that a couple times. And then we get a number in pounds and newtons that we can calculate based on your body weight if that is safe for you to do things. We do that a lot with youth athletes, that's why we got it, but we use it a lot with people with arthritis just to show them the progress, also to see like, another thing that's nice about those objective testing is, the truth is with, let's say knee arthritis, you're gonna have pain, you're gonna probably have some early gains that you're like, oh, I'm feeling much better. But then month 2 to 3 comes along and you're like, I feel about the same. The pain's still there. It still hurts when I do this. It hurts when I get up in the morning. It hurts when I go to a restaurant with a friend and I get out of the chair. But if that number each month is moving up, then you're like, okay, this is, I'm doing more. I'm able to do more with the same amount of pain. That's also progress, right? And because with these types of things, it's like a hockey stick. It's like you make good gains and then that last little bit just takes longer than maybe you anticipate. And that's why we try to set you up for success, so you independently do it. And then you come in and test and you see these numbers go up, and then gradually over time it fades and fades and fades. But there's so many people that are like the Sisyphus, they roll the rock up the hill, they get to a certain point and then they take their foot off the gas or they let the rock go and then they're right back down, and that's that boom or bust cycle. So the objective testing is nice because it keeps that carrot out in front of you. We have people that come in just monthly just to get that test, just to see if they're on the right path. The other thing that's nice about it is like, you can make progress and you could be symmetric, but they're both weak. And even though you didn't have knee pain in the right and the left one's what brought you there, you know like, okay, I need to get them both stronger so I don't develop something on the other side. So objective testing is important to know that what we're doing is hitting the target. And then our end goals are improve load tolerance through a range of motion, and improve force production for your overall functional capacity in life. All right, education and lifestyle. Hopefully that's what I've done here today. Nutrition is out of my scope as a physical therapist. There's a couple great dietitians and nutritionists that we work with, because I do think exercise is good to keep weight off. You cannot exercise weight off, though, right? To lose weight, it is, I used to say 60-40. It's 90-10, 95-5. It is mostly diet and nutrition, sleep, other things. So like, exercise is good to like not let it balloon, but if you're at a point where you need to lose weight, you can't exercise it off, and that's how people actually get pain from like overdoing it. Cardiovascular exercise, not something you're going to do with me in the office, right? Because your insurance company would hate if I billed for you to sit on a bike for a half hour. But we educate you to do it. It's good on some of those light days because, low impact if the joint is sensitive, but like we talked about, running is fine and other things. And biking for let's say a knee is really good because the cyclical motion helps with the cartilage hydration, helps with the blood flow, and it can help with the weight loss if you can't do enough exercise otherwise.
Like the stationary little
Stationary bike, good old fat. That's why Peloton's making so much money. So I wanted to get out ahead of the most frequently asked questions I think when it comes down to, if you can't change or repair my cartilage, how can exercise work? Hopefully you guys have a better understanding of why that could happen at this stage after this. Is that noise bad? Am I causing more damage? It depends. If the noise hurts, it's not good, but typically the noise is more disconcerting and icky and uncomfortable, and not pushing into that is actually worse, right? So the noise is not typically bad. It is what it is. We can't change it, but we don't want to let it cause a further cascade of degeneration and deconditioning. This exercise or movement hurts. Should I do it? That happens daily in our office. It depends, right? And what I mean by that is the soreness rule. So typically, again, we'll keep with the knee. If something hurts, I don't want it to be, if 10's the worst pain and 0's none, I want it to be around a 2 to 3, okay? If it's above that, then we would decrease the intensity or modify the range of motion. If it's a 2 or a 3, and then the next 24 hours you're sore, and you feel it going up and down stairs, getting out of chairs, but then 24 hours later, you're kind of back at baseline, that's good. That's okay. If it's, I'm limping the rest of the day, I don't want to go upstairs, it lasts more than a day afterwards, then that's telling me it's too much, and then we have to titrate and adjust things. So the truth also, as a physical therapist, there's a little bit of a Goldilocks effect to the beginning of it. We got to find that right entry point, and we do make mistakes. But the information back from you guys and us educating you helps us dial it in and get it right. So it depends. But you don't want to, the way you're going to beat it is not pain-free exercise. Let's put it that way. All right, you're going to feel some things doing these things. From an evolutionary perspective, we're also geared that if we have buttery or sugary things, we want to gobble it up because our ancestors didn't have access to all the stuff we have access to. So it's normal to feel that way, and you got to have some good self-control. But yes, sweets are an inflammatory food. But also, I went for a run yesterday. You know what I had before? Jolly Rancher. because it gives me, if I know I'm going to burn it off, then that's fine. Or I take my 6-year-old to flag football. I give him a little treat. It's his energy candy before football. So you don't want to be. The pendulum should swing somewhere in the middle. You should be able to socially enjoy a cake at a celebration with your friends and family. But yeah, it shouldn't be everywhere. Yeah, moderation. Yeah, absolutely. But very good question. Aerobic exercise, strength exercise, and then there's movement, right? So yoga falls into that category. Pilates, dancing, martial arts, Tai Chi. Those things are great, but they're never gonna replace strengthening and aerobic work, if that makes sense. If you're just you won't be able to just dance away your knee pain. But if you do the strength training and the dancing, that could be a good mix. I thank you all for coming by and a lot of great questions and good attention. So thank you very much.
Thank you.